Our topic in neuro is going to be central perfusion pressure. A beautiful discussion indeed. However, before we begin, a couple of foundation topics that I need to make sure that you're clear about. I need you to imagine an oxygen dissociation curve where on the x-axis has a PO2 and will go up to 100 millimeters mercury. And on the y-axis will be something like saturation of oxygen. You should remember that PO2 is the dissolved form of the oxygen. And if we're talking about PO2 at 100, I need you to picture that we're up by the lungs. And we have a P big O2 of 100. It's going to diffuse across the pulmonary bed into the pulmonary capillaries, which is bringing in a PMVO2 of 40, concentration gradient of 60. So therefore, by the time you come to your P little aO2, we're at approximately 100. That's where we are when we say PO2 of 100, and let's say that you drop down to PO2 of 40, and saturation of oxygen will be 75% versus 97%. So that would mean that we're in the veins. Okay, so now that you've recapped the oxygen dissociation curve and you've focused upon the fact that it's dissolved, that no matter how much you increase your PO2, what's going to happen? This is just going to remain as plateau. So I want you to go up to a PO2 of 120, go up to 140. Maximum here dissolved is approximately 100. It is not going to increase any further because you add a saturation of approximately 97%. The reason that's important is when we take a look at our CPP curve, that the formula for central perfusion pressure is mean arterial pressure, and from that you're going to then subtract intracranial pressure. Keep them separate and also picture that. Now, if you remember, cardiac output is equal to mean arterial pressure over TPR, and you solve for mean arterial pressure, and that'll then give you cardiac output times TPR. Now that mean arterial pressure, in which we have TPR, is for systemic circulation, and it's taking the pressure from the aorta, which is approximately 92 millimeters mercury. So with central perfusion pressure, what we're going to do is we will make a range between 50 to approximately 100, then 150, and go all the way up to 200. And we will say that if the x-axis is PO2 again, so this is all millimeter mercury, and there's going to be various factors here, that on the y-axis we will then have cerebral perfusion. Okay, cerebral perfusion. The first thing we're going to take into account will be our mean arterial pressure. And luckily, in physio, in our body, we have a decent amount of autoregulation where if the mean arterial pressure is going to drop over to the left, so if it drops over to the left, and this red curve here represents mean arterial pressure, that for the most part, you notice here that it's firmly anchored at the x-axis. What is? The cerebral perfusion. So as mean arterial pressure is moving from left towards right, it's dropping 150, 150, that ultimately, that no matter how much autoregulation is occurring, if that mean arterial pressure drops, let's say below 50, let's keep it at that, then no doubt that your cerebral perfusion is going to decrease. Autoregulation, once again, from 50, let's go all the way up to about 150, about 140. So you notice here, from about 50 to 150, approximately, that there was no change in cerebral perfusion. Now let's go above 150, and you notice now that you will have an increase in cerebral perfusion when mean arterial pressure gets above the autoregulation. In other words, these are the end of the spectrum here of A and B that we're going into pathology. Okay. So now that you've understood the basics, understood how to dissect the graph, let's now add in some important gases. We're going to begin with the most important gas for regulating cerebral perfusion, without a doubt, is going to be carbon dioxide. Remember that carbon dioxide is the only gas that is then detected by the central chemoreceptors. Not peripheral, but the central chemoreceptors. So in the medulla, we know that carbon dioxide ultimately will pass through the blood-brain barrier. And let's say that our individual is increasing carbon dioxide. How would you go about increasing carbon dioxide? What do you mean? Well, tell me about ventilation. You'd have decrease in ventilation. So when you have a decrease in ventilation, picture that. So when you hypoventilate, right? When you hypoventilate, you decrease your ventilation. And so therefore, what you're going to find is you're going to find an increase in carbon dioxide levels. So let's go ahead and say green. I'm going to start increasing. But notice, this green curve here represents PCO2. PCO2. And you notice here, we're going to interpret this as being from right towards left. We're going to move up this hill. All right. If you're moving up that hill, it means that PCO2 is rising. If that PCO2 is rising, your breathing pattern is hypoventilation. You know that normal PCO2 is between, let's say, 35 to 45. 35 to 45, right? PCO2, we'll say approximately 40. So you notice here that if you're hypoventilating, that as far as the brain is concerned, that this is then interpreted as being, oh goodness gracious, I'm not getting enough oxygen. So reflexively, what's going to happen? Reflexively, in the cerebral blood vasculature, you're going to undergo vasodilation. Vasodilate. So as your PCO2 is rising because of hypoventilation, reflexively, your cerebral vasculature is going to vasodilate. If you do that, what's going to happen in cerebral perfusion? It's going to start increasing. There you go. All right, well, if you continue eternally to vasodilate, what's going to happen? Oh my goodness gracious, it's going to be so much vasodilation that ultimately you're going to then result in vasogenic type of edema, aren't you? Vasogenic type of cerebral edema. So therefore, you can't have eternal vasodilation. The cutoff point is approximately CO2 of 90. So when you're hypoventilating, no matter what, at some point at approximately 90, you're going to plateau off. You're going to plateau off right there at that crux at approximately 90. Because as I said, any further vasodilation is then going to cause cerebral vasogenic type of edema. You can't have that. On the same note, well, what if you hyperventilate? Let's go down the hill. For what? PCO2. So if you go down the hill, it means that the PCO2 is dropping. Right? PCO2 is dropping. If you go down the hill, the PCO2 is dropping. What's happening to the cerebral blood vessels? Well, it's undergoing vasoconstriction. Vasoconstriction. Oh, that makes perfect sense, because if you hyperventilate, you are now blowing off more carbon dioxide. As you blow off more carbon dioxide, well, obviously the oxygen is being reached, or the brain is receiving the oxygen, and so therefore it's going to then undergo vasoconstriction, which is coming down that hill. The reason that's important is, let's say that your patient has a stroke. And secondary to stroke, that patient has developed cerebral edema in an acute fashion. Cerebral edema in an acute fashion. The conventional methods of reducing the swelling within the head is not working. So what you're going to do is then institute a hyperventilation therapy. It's called hyperventilation therapy. Look what happened. When it was hyperventilating, the carbon dioxide was dropping. Right. If the patient has cerebral edema, what state of your blood vessels would you like them to be in? I would like for the cerebral blood vessels to be vasoconstricted. the conventional methods of cerebral edema reduction did not work. So hyperventilation therapy, by decreasing your carbon dioxide in your cerebral blood vessels undergoing vasoconstriction, may then help you with acute cerebral edema. So far, we looked at mean arterial pressure. We looked at PCO2, and if you're hypoventilating and you get to PCO2 of 90, then at that point, you're going to have no further vasodilation, no further increase in cerebral perfusion. We looked at when you're hyperventilating, for example, in hyperventilation therapy. When you decrease the carbon dioxide, your blood vessels are undergoing vasoconstriction, therefore could help you with cerebral edema. The last gas that we need to add in here, obviously is going to be oxygen. Now we're going to do the same thing. What I mean by that is, let's say that this blue curve here represents oxygen. Notice on the x-axis for oxygen, PO2 100, 150, it is synonymous with the plateau phase that I showed you here of the oxygen dissociation curve. In other words, no matter how much you try to increase your dissolved oxygen beyond 100, you really can't significantly increase the SaO2. Same concept. Here, you notice as the oxygen on the x-axis is moving from left to right, that you're going to have plateau. You're not going to have really significant increase in any type of perfusion. Now, what then happens now is that at some point in time, if you find that your oxygen levels are going to drop below 50, look what happens. So oxygen now, let's move from right towards left now. So as you move from right towards left, you notice that the PO2 is dropping from 100, 90, 80, 70, 60, 50. The brain doesn't like this. The brain doesn't like this. So when your oxygen levels start dropping below 50, less than 50 millimeters of mercury, look what happened to the curve. It increased, but you must be able to interpret this from right towards left. And as you move from right to left, in that direction, moving up, exponential curve, you notice that there was a rise in cerebral perfusion. But that only occurred when your PO2 drops below 50. So it's safe to say that the most important detection and the most important determinant of cerebral perfusion in terms of gases, no doubt, is CO2. It is only at the extreme cases of PO2, when it drops below 50, in which you would then find a rise in cerebral perfusion. The last little bit that I need to bring to your attention is something called Cushing reflex. Cushing reflex. Now, what Cushing reflex means is that it begins with your patient having an increase in intracranial pressure. And remember, CPP is equal to mean arterial pressure minus intracranial pressure. Imagine if you start increasing your intracranial pressure due to a tumor, a hematoma. When that intracranial pressure increases, you can then imagine that the cerebral perfusion pressure is going to drop. So you must begin with the space-occupying lesion. SOL stands for space-occupying lesion. That's going to increase intracranial pressure. That's Cushing reflex. Now, once that occurs, to then overcome the decrease in central perfusion pressure, you must then increase your mean arterial pressure. Hence, the triad in Cushing reflex, number 1, is going to be hypertension. That hypertension referring to the fact that mean arterial pressure must increase adequately so that it's able to then overcome the initial increase in intracranial pressure due to a space-occupying lesion. Number 2, due to that increase in mean arterial pressure, your baroreceptors are going to increase the firing. It's going to increase the afferent firing. You increase the afferent firing, the body then interprets that as being increase in blood pressure. So immediately, you're then going to decrease your sympathetic nervous system outflow, and you're going to be suffering from bradycardia. That's a second parameter, or part of the triad for Cushing reflex. Number 1, hypertension. Number 2, bradycardia. Number 3, because of that increased intracranial pressure due to a space-occupying lesion, it may then restrict breathing. So you're going to have decrease in respiratory rate, decrease in breathing. In other words, hypoventilation. The triad includes hypertension, because you're trying to overcome the increase in intracranial pressure so that you can then restore central perfusion pressure. Number 2, you're going to have bradycardia due to the increase in afferent signaling of the baroreceptors. And number 3, you're going to have a decrease in respiratory rate, most likely due to that hematoma, maybe perhaps, then compressing the brainstem.